Welcome to our session on the importance of mental health care in critical illness. This is Dr. Maria Luisa Guinto, and I'm from the University of the Philippines. Now, let's begin by looking at the numbers. What is the mental health data? Believe it or not, there are close to 1 billion people worldwide living with mental disorder, and close to 6 million cases in the Philippines of reported depression and or anxiety. Records also show that mental illness is the third most common disability in the country, and 1 in every 5 suffer from mental illness in the Philippines. Close to 2.5 million in Manila reported mental health cases, and women are 1.5 times more predisposed to mental illness than males. And this condition usually peaks in older adults. Why? Because of retirement, isolation, losing a partner, and physical illness. And this is what we're going to focus on today: physical illness. So, everyone and anyone can be vulnerable to mental health illness. You and I are not exempted, not even me as a psychologist. I am not exempted from mental health illness. So, what I'd like to emphasize here is mental health matters to all of us, young and old, male or female, sick or not sick. So, what is mental health in critical illness care? Now, let's look at research. The first finding shows that approximately 50% of critically ill patients suffer serious emotional distress, often characterized by anxiety, grief reactions, low mood, and panic. Another finding also shows that these emotions may relate to the fear of dying, invasive treatments such as ventilation, pain and discomfort, inability to communicate, and terrifying hallucinatory delusions. Another finding also shows that up to two-thirds have unusual experiences such as hallucinations and delusions while in the ICU, and that these have been linked to the medication for sedation, the critical illness itself, the fact that the patient is not mobile or even restricted or restrained at times, and there is sensory and sleep deprivation. All of these factors contribute to the experience of all of these mixed emotions. So people who have been discharged, in particular from the ICU, have been quoted to say, for example, I get panicky if I go out alone in case I'm taken ill. Takot ako lumabas. Ayoko na. I get very angry with my family. They keep fussing when I try to do things for myself. Parang wala akong magawa para sa sarili ko. I also feel very angry with myself for not getting back to normal by now. Ang tagal na nito. I also try to help by doing some washing up, but I keep dropping dishes. And I can't seem to help. Well, when I first came home, I climbed the stairs using my hands and knees, and I came down on my bottom. Are any of these familiar to us on a first person point of view, or someone who has witnessed a loved one or heard a loved one express these statements? So, how do people feel when they are treated for critical illness? First, obviously, they feel physically weak. They can't do everything they used to do. That's why they are being treated. Simple tasks that seemed to be easy before are no longer easy. Fatigue sets in easily, sometimes the whole day. Laging pagod. Little things make them tired, even little tasks, self-care tasks like taking a bath, changing clothes, or even eating can be very tiresome. There's also numbness in other body parts due to also the treatment, and feelings of breathlessness, no? Madaling maubusan ng hininga, madaling hingalin with very simple tasks. And this comes with the feeling of fatigue as well. Changes in appearance, sudden drop in weight or increase in weight, loss of hair, scars, amputations. These are all realities that come with critical illness treatment. Changes in voice, hoarseness, especially when ventilation is done or some tubes have been inserted through um, the throat or esophagus, and feeling mentally different. What used to be an easy reading or task, let's say understanding something or writing something, becomes very difficult. Memory is also faulty and sometimes lacking. Okay, there are also emotional changes like mood swings, getting easily irritated or easily offended, feeling very sensitive, okay, to other people. And there is also overwhelming anxiety or worries, about what will happen to me, how long will I live, what will happen to the people I will leave behind, how much burden I'm causing to other people. There's just this constant worrying and anxiety. And of course, recovery and rehabilitation after critical illness can take longer than expected. It can be unpredictable to some people, and that can be very, very challenging. Now, psychologists usually call this phenomenon post traumatic stress disorder, or PTSD. So PTSD refers to a collection of symptoms that some people have after their life is in danger or where there is a threat or possibility of suffering serious injury. So, for example, figuring in an accident can really trigger post traumatic stress syndrome, where you were really threatened because you met an accident, maybe car accident, but this can also happen in illness upon hearing the diagnosis, for instance, that you are sick with a critical illness or a terminal illness, let's say cancer or even COVID-19. And you can also be affected with PTSD when you witness others suffering, let's say killings, you're a first-hand witness in a murder or in some great suffering, or you hear of some suffering of a loved one or a friend or somebody who's close to you. Therefore, caretakers or family members who take care of their loved ones who are sick can also experience PTSD. Okay, so why does this happen? What is it with hospital stays or getting sick that can trigger trauma? First, when you receive the diagnosis or the bad news and thoughts about what this meant to you or for those you love really flood into your mind, and that moment in time can actually be very, very traumatic because it is something that you didn't expect and that you had no control over. So, two of the characteristics of trauma is that it is unpredictable and you could not have stopped it. That's why it becomes traumatic. If you knew it was coming and you were able to manage changes or adversity in your life, then that's not traumatic. So challenges are different from traumatic events. Adversities that come into our life that more or less are part of growing up, or maybe opening up a business, or doing something. These things are more or less what do you call this, predictable. But okay, illness, especially critical illness, is not. So Moments that you believe that you could die or might die. So, for example, you're in the ICU and you have all of these contraptions around you and tubes, and you get to think about, like, I might not even wake up tomorrow. Those are very traumatic moments. Being faced with frightening, invasive, and even very painful medical experiences. I mean, just think about, let's say, your first experience of having your tooth pulled out, or let's say the first time when you were a young child that you experienced vaccination, or even getting a serious wound. Those are very frightening experiences. So when you are subjected to these inside the hospital, then that can be part of the traumatic experience. And when you experience hallucination caused by medication or delirium or other forms of illnesses that trigger, seeing, feeling, and sensing all these scary, what we call this, images, that can be traumatic. So even if it's a hallucination where, contrary to reality, it feels real, and that is scary. So experiences where you also felt very powerless, or where you felt you weren't being helped. So for example, um, in the ICU, when you're attached to all of this and there's a moment of awareness and you don't know where you are, you're worried, you're scared, there's no person to explain to you where you are. That's really the height of powerlessness. And sometimes, especially during this pandemic, where there's a short of hands of medical health workers, and patients are not immediately attended to, and they get scared, they get frightened. That's part of what is also very disturbing in their experience in a hospital. And the very experience of being in an ICU is invasive, because a lot of equipment and items and medications are given to you without your choice or consent. Maybe the consent of your family, but definitely not yours. And so that experience, that environment already brings about um, these characteristics of trauma. All right, given that this is the reality, is there a way we can recover from this? Definitely. But first, we need to understand the mechanisms of trauma. Now, the perception of danger and the reaction to it has a survival value. Because if we didn't even perceive that there was danger or threat, how can we act? The difference is, in a traumatic situation, there is really danger. It is perceived, okay, by the brain, particularly the part in the brain we call the amygdala, and the body prepares for action. Now, during a traumatic experience, the threat system continues to operate on a high alert level, even when the threat is gone. So, for example, um, when you perceive that your life is in danger because of this illness, even when the doctor clears you and when you go home, it continually intrudes in your thought, no, all the treatment that you got, and the worry that it might recur. Okay, I remember, for example, uh, a client I had before who tore his ligaments in around the knees because of sport. Now, even if the doctor cleared him already, he could not go back to playing high performance sports because of that recurring memories of how he injured his knee and during the game, and how it might occur again. So the threat system, the hypervigilance, the emergency situation sensation stays active on a prolonged period of time, and that can be very debilitating. And that's one characteristic of trauma. It can actually be very distressing and debilitating. The thing about trauma also is it brings about memories that are very different in characteristic from the memories that we normally have. So first, it has a sense of urgency and immediacy. It's like the thought or the image that comes to your mind really drives you to escape, to do something about it, or to be in a fight mode. And the memories are very vivid: the sight, the sound, the smell. Okay. So, for instance, um, just walking by a clinic or passing by a hospital will vivify your experience of being inside the hospital, but you're just in the car and passing by. You just saw the facade of the hospital, for instance. And it is involuntary. The memories come without you even dwelling on them or thinking about them. They're like intrusive thoughts that bring about emotions. Intrusive because they are like robbers that intrude into your house. The thoughts intrude into your peace of mind and in your memory, whether you like it or not. And they come in fragmented form. No, not even the whole story. There's normally a magnification of that particular horrific sensation or experience. Okay, so for example, the experience of losing your breath while being rushed to the hospital or struggling through the treatment is something that is very scary that you would never want to experience again. And therefore, just, uh, fatigue or catching your breath once in a while already makes you panic. But the good news is PTSD is basically about meaning making. It's about attaching meaning to particular events. While the initial encounter may have attached fear and panic to that particular event, it is also by reattaching new meanings that we are able to get well from it. Of course, the process is a little bit more complicated and complex, but there is a way, and that is why we are talking here about um, mental health care for those who are critically ill, because we have to be part of that constructive process of reassigning meaning to the experience of being in the hospital and being treated and receiving all of this health care for the illness. So what makes PTSD very distressing and part of what keeps it going in the mind and in the heart and in the emotion of the person are the ways by which that person made sense of what initially happened. So sometimes those interpretations or meanings may have basis, but other times they're off the mark, either exaggerated or inaccurate altogether. For example, um, going through major surgery, let's say a triple heart bypass. Of course, that is really potentially traumatic because it's an invasive procedure. But in this day and age, okay, a lot of procedures have already been done similar to this. And the process has been mastered by a lot of doctors who specialize in the field. And therefore, um, sometimes the memories or the images of what we thought happened during the procedure can be very disturbing, especially about how the heart has healed after, for instance. But the idea or the thought that my heart was invasively, what they call this, um, uh, you know, treated by the doctors is enough to really disturb us every now and then. So we need to work through our thoughts and beliefs because they are the ones that drive our feelings and our sensations. So we also have to look at our behaviors of coping because people who feel very distressed with their illness sometimes adopt behaviors that may be counterproductive. For example, avoiding reminders of what got me sick or things like that. But avoiding it forever or in the long term may be counterproductive because those reminders will also help us, okay, stay safe in, let's say, eating habits or routines that are healthy, okay, and avoid those that triggered the illness. Avoiding reminders altogether also can be counterproductive because it can prevent us from seeking continued help. Okay? Or people don't want to talk about what happened, okay, tapos na yan, etc. But not talking about it also might prolong the process of healing from the trauma because science also shows us that relationships and being able to talk about difficult matters can help, okay, with trusted and non-judgmental people, okay. Using alcohol or drugs can also be a coping mechanism, but definitely it will create greater health problems, all right, because they can develop addiction, we can be dependent on them, and of course other parts of our body will suffer as well. We can also be very obsessed with checking ourselves or scanning our bodies for symptoms and assessing every now and then. While that is good, it can be counterproductive because it can also be an obsessive search for symptoms that may be trivial, but we may tend to exaggerate. Okay, so these need to be assessed also, these reactions, these routines, these coping mechanisms, not just thought patterns but behaviors as well. So is it possible to manage critical illness induced PTSD at home, okay, even if we are not professionals? Yes, of course. It's like first aid, no? You don't need to be a doctor to do first aid. We do that also with our loved ones. First, we must educate ourselves. We must learn, learn, learn. First, learn about the ways that physical illness can affect us psychologically. The body and mind are all in one person. When we get sick, there are consequences in the mind. When we are mentally ill, there are also physical symptoms. So let's dissuade ourselves from that dichotomy of my body is sick but my mind is okay, or my mind is ill but my body is okay. No, it's the same person. So we need to be able to understand that the person is whole. Okay. Then we also learn about the objective environment of hospitalization and critical illness care that can bring about, okay, these reactions, the invasive procedures, the prolonged stay, the sedation. We must be able to understand that. And we must also be able to prepare ourselves if we are, foreseeing that this will happen. If it is after the fact, then we must be able to understand why our family member, the patient, our loved one is suffering a lot. We need to understand that. The second is we need to accept all of these things without judging. We must understand that we may have this um, body reactions or body memories that we cannot really control. Okay, they are there. They're part of our muscle memories, so to speak, of what happened. And so we honor that and we accept that in ourselves or in our loved ones if they are experiencing difficulty. We also need to accept that there may be gaps in the memory because at the greater part of the hospital stay, for instance, they were in the ICU and they were sedated, or we were sedated. And so, what could help when the time is right and when the patient is ready is to go over the medical records. There are daily logs that will show what actually happened, what transpired, what you went through, what were done to you, so that you can fill in the gaps, so that you don't need to panic that you're having amnesia or you're suffering or you're losing your mind. But these are natural effects or consequences of long-term sedation, drugs, and other what do you call this medications that you received. So trying to piece together what happened through those medical records or even narratives of your loved ones can help. And then, of course, we go to what I mentioned earlier, the reassignment of meaning. The same experience, the same events may be talked about from a different lens when the person is able already to go to this stage. Okay, of course, we do not invalidate the thoughts, feelings, and experiences of the person. Okay, that's why we accept without judging. And then later on, we help them identify what are the helpful and unhelpful interpretations of events that could lead to continued distress and trauma. So, for example, thinking that all the doctors and the nurses or everybody who wears white, okay, will bring me pain and will not really think of my welfare may not be a very healthy meaning making. Okay, it is possible that a particular doctor who shows more warmth and compassion could also be representative of other medical health workers, not all medical health workers or nurses or doctors who I experienced in the hospital made me suffer. Okay, so psychological treatments for PTSD usually involve updating these unhelpful meanings or interpretations in the mind, and also looking at all these coping mechanisms that are helpful and unhelpful. Now, family, friends, and church community members have a role to play in helping the person manage these and recreate meaning as well. Okay? And when we talk about spirituality and faith, science has something to say about it also, because studies reveal that um, spiritual coping is very important as a protective factor against both mental and physical illness. However, spiritual struggle is also contributory to illness. What do we mean by spiritual struggle? Guilt, anger, unforgiveness. Okay? So if these emotions are cultivated at home, for instance, or in the community uh, when people feel guilty, for example, for not professing the same faith or belief or practices as the family or the community, and they feel guilty, they feel less worthy, then these are very toxic feelings. Okay, so while spirituality is supportive, the reverse of spiritual struggles and spiritual dissent, for instance, can lead to greater distress and ultimately illness. So science acknowledges the importance of faith in health. So this is the good news for everyone, especially for us here in the Philippines, where spirituality is really part and parcel of our everyday lives. No? And sometimes, we feel very apologetic that instead of, for instance, relying on medical science alone, we pray. No, now there's no need to choose one or the other. Both can actually do good, and medicine itself is acknowledging faith and spirituality as important in the whole intervention process. So faith in God has been found to allow people to deal with horrendous suffering and even life-threatening illnesses. And so for those of us who have family members or community members or church members who are suffering, this is good news. So I'd like to propose that a psychospiritual care be considered. So first, again, I go back to what I said earlier. Let us educate ourselves. We need to read, we need to study, we need to consult professionals, okay, on the situation of the person who is experiencing critical illness and those who care for them. And we need to be very deliberate in terms of the quality of information and the source of information, because especially during this day and age where there's an explosion of knowledge and information at the same time, misinformation, fake news, then we have to be very careful. Let us educate ourselves, find out what are the psychological implications of physical illnesses and what are the effects on people who also take care of them, who are well, but could also be in danger or at risk for mental health issues. And then we have to really practice active listening. When we say active listening, we're not just hearing, we are engaging our hearts and in our minds in listening to the other person. This means that we listen to what is said and how it is said. Acknowledge the experience and suspend judgment. Okay? And this brings me also to the third component, which is showing compassion. Compassion means accompanying the person in suffering, being there. Presence is itself is very important. So here we talk about also modeling God's love. God's love that is willing to be present with us always. And so being compassionate with our family members and even those who care for those who are sick means that we are willing to be with them, to walk with them, and go through them through this difficult time. Offering prayers is also very important. Even if people are initially resistant to it, it is very hard to say no to a person who asks, would you like me to pray for you? How may I pray for you? Let's pray together. Because when people are very ill, it is the biggest opening also to God's intervention. Not just medical intervention, but God's intervention as well. We can draw from the scriptures as we pray, but we must also be careful that it is timely and also acceptable to the person. Because sometimes we may be so eager to share our faith or to share the gospel, but we are not sensitive also to what the person is ready and able to receive at the moment. Okay? So think about that. And then, of course, finally, we need to also help ourselves in seeking help, especially from professionals who are trained in mental health. Now, there's a lot of stigma when it comes to approaching mental health providers like psychiatrists and psychologists. And so it is part of our service to educate our family members on this and to treat mental health services as just like other the medical health services that we seek when we are sick. So it's just like going to a dentist. Okay, going to your psychiatrist or psychologist can be as ordinary as that, but we have to model the way as well. So looking for mental health professionals can be part of our care, and also um, accompanying them if we have to. Of course, nowadays there's such a thing as telepsychology or a teleconsult, okay, where you can consult your psychologist or psychiatrist via online platforms. But sometimes making that first step is very challenging, and maybe we can help in that. Okay, when do we seek professional help? That's always a question that I get. I borrow these 4 Ds, okay, um, in terms of making it easier for people to understand. There are 4 Ds or four red flags, as I would say, that will really tell us that perhaps it's no longer enough for us to just do home care or maybe first aid, but really we need to seek professional help. So first is deviance. When the reactions or when the situation is already very different from what normally occurs as a result of illness, And as I mentioned a while ago, many of the abnormal reactions are normal reactions. But when it deviates even further from that in terms of frequency, intensity, and also the context, okay, of where it is happening and how it has happened, when you sense that it is very far already from what is expected, then perhaps there is that first D sign, deviance. The second is distress, when the person is already suffering from the experience itself. There is intense distress. Hindi na siya makatulog. There is no more what we call this happiness. Okay, there's extreme distress. And then there's also dysfunction. Of course, physical illness will bring about certain dysfunctions, but mental health issues can even further that. Okay, when the person's fear is overwhelming and the person can no longer function, cannot even go to the hospital, cannot even see other people, cannot even do self-care, very basic, for instance. When there are extreme forms of dysfunction, perhaps this is already the third D that will already signify that you need to seek professional help. And finally, danger. When there is a danger to the person himself, like for example, self-harm or continued lack of sleep, lack of appetite as a function of all these experiences, then it may be time to really seek professional help. So those are the four Ds: deviance, distress, dysfunction, and danger. Okay, so let me pause at this moment first so I can give the floor to your questions, comments, insights, clarifications, and we can make this discussion even more um, uh, uh, encouraging to all of you and helpful. So let me pause and give the floor back to you. Thank you.